So my name is James Yakubu, and I want to welcome you to this module on Introduction to Antimicrobial Consumption Surveillance. Previously, we had discussed the definition of antimicrobial stewardship, and we had also looked at the core elements of antimicrobial stewardship. We had also considered the steps in establishing antimicrobial stewardship at facility level, and now we want to look at surveillance of antimicrobial use. And why do we go into surveillance of antimicrobial use? This helps us to understand the quantity of antimicrobials used at the national, regional, or facility level. And when you do that, you would have created awareness, including policymakers and healthcare professionals. They would become aware of what antimicrobial stewardship is all about. It also helps us to compare use of antimicrobials over time across facilities or even between wards in the same facility. It also helps us to identify targets, benchmark, and inform interventions through the antimicrobial stewardship. Access, it helps us also to assess impact of intervention to promote appropriate use of antimicrobials. And that also helps us to create an early alert system to say, oh, there appears to be some kind of resistance to these particular antibiotics, and therefore informing some intervention programs that you might want to institute. It also helps us to correlate. Okay, so this has really been very useful across, to compare the way that antimicrobial agents are used. And in European countries and the EEA, that is the European Economic Areas, this kind of surveillance has helped to inform the DDDs across different countries, as you can see. So the darker patches indicating that there is massive use of antimicrobials in those countries, and the lighter patches showing that there is not so much of the overuse of antimicrobial agents. So you can represent such kind of comparisons, over time, and as you can see in the graph, showing how that antimicrobial use has been compared over time. Again, you can use that to compare antimicrobial resistance vis-a-vis antimicrobial consumption, because when there is overuse of antimicrobial agents, then of course we expect that there will be increase in use of cephalosporin, also result in increased resistance to ceftriaxone. So antimicrobial consumption and use can be shown across the value chain or the supply chain of antimicrobial agents, which start with research and development, and of course regulations in countries and regions, and then move into selection into essential medicine lists of various countries or even WHO. And then of course it will then be procured and distributed, and then prescribing of medicines and diagnostics. But then of course where the use really consumption starts is at the pharmacy, where you have the medicines now, the antimicrobial agents now being dispensed. And of course you can also see that at the end of it all, it is being used by the patients. So there's accuracy and coverage as well as resources. The higher the point for data extraction in drug supply chain, the better the data. What that simply means is that the data that you get at the level of research and development would not be as useful in determining consumption and use as you would get at the level of the pharmacy where you dispense these medicines, or at the level of use when it is already dispensed to patients. So why do we measure? If you can't measure it, you can't improve it. That is a very significant code. It helps to convince your audience. It helps you to plan your action. It helps you to monitor your progress. It helps you to evaluate your plan and also future planning. Fact must be scientific, gathered in a systematic and logical way. So the WHO has a tool for measuring consumption and use at both national and facility levels. So the data sources or source to use, you will have to consider what is desirable and what is realistic. Is there consistent access to the chosen data source? Does the quality of data depend on data extractor? And that speaks to reliability. Ideally, everyone involved in extracting data should be able to turn in the same result. Data sources may evolve and change over time, but it is important to note when this happens. So you take, for example, you could be collecting your data manually, and all of a sudden you have technology coming in. You have to take note of that and adjust accordingly. So antimicrobial use and antimicrobial consumption. The antimicrobial consumption essentially estimates quantities and types of antimicrobials used, whereas antimicrobial use is the estimate of the actual use of antimicrobials. So it is patient-based, it is at the level of the patient. In other words, it will go with prescription and point prevalence surveillance, whereas in consumption, it is based on aggregated sources, imports, production, distribution, sales. So it is an aggregated data. So to further buttress the differences between consumption and use of antimicrobial agents, we would say therefore that in consumption, it talks about aggregate data source. There's no information on patient characteristics and indications, whereas in use, individual level information, you have it has to do with individual level information. And in consumption, it is based on sales of antimicrobial medicines, whereas in use, information on patient characteristics, e.g. gender, age, weight, etc. Are involved here. Then there is complete data in consumption, but while in use, it provides more accurate information on use than consumption data. So these are just some of the parallels that you could draw between consumption of antimicrobials and what you call use of antimicrobial agents. So antimicrobial methodologies for measuring antimicrobial use and consumption are not mutually exclusive, but complement each other. Weekly collection of data on antimicrobial consumption, collect antimicrobial use data. So all these, you put them together. So the methodology used to estimate use and consumption are not mutually exclusive. Let us try to draw a comparison between antimicrobial use and antimicrobial consumption. Now, it is important for us to know what antimicrobial consumption surveillance is all about. And in simple definition, we could just say that the systemic collection that antimicrobial consumption surveillance refers to systemic collection and the reporting of aggregated data of antimicrobial cells without patient information. It is very important to note that this is without patient information, which is then analyzed and interpreted to guide antimicrobial stewardship interventions. So how does data flow from the facility and across the hierarchy of the antimicrobial resistance program? It flows from health facility to stewardship sub-technical working group, and then to national antimicrobial technical working group, and then to antimicrobial resistance coordinating unit, and that flows into the One Health, or what you call the National One Health Technical Committee, and then the National One Health Steering Committee. So that is the flow of data in antimicrobial stewardship program. And there are principles that guide this flow of data. And you have to know, as principle number one, what to monitor. This includes the annual collection of data on systemic antimicrobial consumption at national level. So there are different categorization of antibiotics. And so you have systemic antibiotics as categorized by WHO JO1, A07AA. These are anatomic, therapeutic, and chemical categorization of antibiotics. So no antimicrobials for topical or skin or other local use are included in this, are to be monitored. Basically, it is the systemic antibiotics that are considered. So you can look at all the systemic antibiotics. Principle number two, what health sector to monitor? So you can monitor hospitals and communities. You can also monitor public and private health facilities. And then the principle number three is, what data do you collect? It is important to note that you have to collect data at the product level, which will refer to the substance, the strength per unit of the medicine, number of units sold. It could be tablets, it could be vials, route of administration, and of course ATC code, which refers to the anatomical, therapeutic, and chemical codes. Principle number four, how to measure. How do we count and aggregate antibiotics to measure consumption? You can do that by number of units, either in tablets or in vials. You can do that in number of grams. Principle number five, data type. For comparison purposes, data on population size is required to adjust volume of antibiotic consumed to the size of population monitored. Population size would depend on data coverage, and data coverage is split into two: complete coverage and incomplete coverage. Complete coverage, of course, referring to total population in, say, hospital or local government or state, whereas incomplete coverage will refer to population size covered, say, in a ward. Antimicrobial consumption surveillance key analysis would include the defined daily dose, which will then flow into the World Health Organization aware categorization, and then the anatomical, therapeutic, and chemical classification, and then it will then flow further to temporal, which refers to data that is collected over a period of time, or administration route, which refers to the route through which the medicine is administered. It could be parenteral, it could be oral, and then of course child-appropriate formulations, which are either syrups, suspensions, etc. So antimicrobial consumption surveillance data collected at product level for the purpose of emphasis will refer to substances, will refer to the strength per unit, it would refer to number of units sold, either in tablets, vials, caplets. It will refer to routes of administration, and like I said earlier, ATC code. So it is important to note that the ATC classification and the defined daily dose are indexed by World Health Organization Collaborating Center for Drug Statistic Methodology, which is domiciled in Oslo, Norway, and this is the page, so you can always refer to it and then carry out your calculation for defined daily dose. It is important to note that when you calculate your defined daily dose without a denominator, it will not make much for inference. But when you have a denominator, say the population as the denominator, then you'll be able to use it, and it will be very helpful in categorizing or making comparisons between healthcare facilities or wards. So let's take a good look at the defined daily dose and how it is calculated. Of course, not forgetting that you can always refer to it in the WHO website. It is a standard metric for reporting medicine use. DDD is the assumed average daily maintenance dose for drug main indication. So as you can see, DDD is defined as the quantity of drug consumed times strength of drugs divided by the World Health Organization defined daily dose, which also means total grams used divided by DDD value in grams. So a very good example, as you can see, is that of the district pharmacies and PMVs in AMAC FCT Abuja. Let us also assume that the population of AMAC FCT is 1.7 million people. If you were to calculate the consumption of ciprofloxacin utilizing DDD methodology, it will translate into 5,000 defined daily dose of ciprofloxacin in 1 week and 714.3 defined daily dose in 1 day. So once again, at product level, as you can see, you have cefepime 2 grams and cefepime 1 gram. So as you can see, as earlier established in the study conducted in the EU EEA, this is an example of presentation of data analyzed in Nigeria, and so there is different color coding to show the intensity of use of antimicrobial agents. So as you can see, this is a summary of antimicrobial consumption data analysis results. And so at the level of defined daily dose, you are able to establish rising trend or increased use of antimicrobial agents. The aware categorization also helps you to determine consumption of access group of antibiotics, which is usually supposed to be 60% according to the World Health Organization. It also helps you to determine consumption over time. Antimicrobial consumption surveillance is a key component of antimicrobial stewardship program. It helps you to review data. It helps you to compare the current situation with previous weeks, months, seasons, or even years. It helps you to determine if any unusual pattern is evident. It helps you to consider possibility of any unusual pattern occurring in relation to trending health events. That could be pandemics, epidemics. It helps you to report to the antimicrobial stewardship team. Antimicrobial consumption surveillance also helps you to investigate and confirm any trend with regards to resistance occurring at your facility or community, etc. It helps you to also prepare your response, how you respond to resistance pattern occurring in your facility, community, etc. It is important to note that once antimicrobial consumption surveillance is conducted, the antimicrobial stewardship team needs to review the data, compare the current situation with previous weeks, months, seasons, or even years. They need to determine if any unusual pattern is evident. So in this case, you have to consider the possibility of any unusual pattern occurring in relation to trending health events, whether it is known or it is unknown. Then you would report to the antimicrobial stewardship team, and then they will carry out an investigation and confirm. Then you would then respond if it is true, and then determine the kind of intervention that needs to be instituted. You will then communicate and provide feedback to healthcare workers, and then finally evaluate and improve the system. In line with the antimicrobial consumption surveillance action plan, it is always important to ensure that when you conduct antimicrobial consumption surveillance, you plan, you do, you study, and then you act. Thank you.